I did my surgical oncology in 2020. Now I'm a consultant in surgical oncology in Aishwarya Cancer Center, Aishwarya Hospital, Chennai.
Yes, sir.
I did my MBBS from Pondicherry. I did from MS from Pondicherry and MCH surgical oncology in Chennai. So I'm currently practicing surgical oncology
Sorry,
for
sir.
the past 6 years.
Your field experiences, how you feel like, what is the things you are facing in oncology? Basically,
Yeah.
for the facilities, what are the types of facilities are there and the patient load in the hospitals?
In our hospital, you mean?
Yeah, sir.
In
And
our
in general, you
hospital,
know what about
yeah.
it?
In Chennai, it is almost like a metropolitan city. So the population is also high. In the same way, the cancer burden is also little high.
Yes, sir.
So we deal with all cases of oncology, like starting from head and neck cancer, thyroid, thoracic cancers, lung cancers, breast cancers, gastrointestinal tract cancers like stomach, esophagus, colon and rectum, pancreas, liver, and kidney cancers, and also skin cancers and musculoskeletal tumors, bone tumors, and muscle tumors, and also gynecological cancers in women, that is ovary, uterus, and cervix cancers. So these are the
So in
common
these
cancers we encounter.
most commonly, what do you think, like, what is the most malignancy in between these cancers?
In men in the Indian population, the most common that we encounter is head and neck cancers, especially because of the use of tobacco in any form, smoke or smokeless tobacco. That is the main reason why the head and neck cancers are the leading cancer among men, Indian men, and in women, the most common is breast cancer here. And the next is lung cancers, and also in women, gynecological cancers, that is the cervix, and preventable breast cancer is also becoming very common now. And apart from that, GI
Yes, sir.
tumors like colon cancers, rectum cancers, these are a few tumors which are increasing in number when compared to the last decade. It is increasing in number, and especially in the northern part of India, head and neck cancer almost encounters for the 60 to 65% of the cancers. That is because of extensive use and lack of awareness of tobacco and its tobacco-related products usage. We are not aware the harmful effects that the smoke and smokeless tobaccos have. So this is how they present with.
And like, which stages they are mostly reported to you?
Since we are in a metropolitan city, the awareness is a little bit high. So 70% of our population presents with early disease. But in other parts, which is the rural areas, lack of awareness is the predominant thing, is the lack of awareness. And the access to high quality facilities is also less. So in rural population, the presentation is the opposite. 70% presents with advanced stage disease, because even though I am from a metropolitan city, I am born and brought up here in Chennai. I practiced surgical oncology for a year in Mission Hospital near Vijayawada. It's a small village,
Okay.
so they have a good cancer facility which is run by Christian Mission Hospital. So it is almost, the treatment is almost free, not completely free. It is sponsored by the government and the Christian missions. So there, when I was shocked to see that 70% of the population presented with advanced disease, which is very rare in Chennai. Chennai, Mumbai, Hyderabad, Bangalore, Delhi. Maybe I don't know, because the access is easy. A lot of oncologists are available. There's a lot of awareness. So and the patient is also well educated and aware of the scenario that he is undergoing. So he presents a little early. But when this 1 year, I was shocked to see that there were a lot of patients presenting with advanced disease.
And as you said earlier, sir, you visited Assam too. So is there the same scenario is same for that city, tier 2, tier 3 cities are
Yes,
same?
yes, yes. See, in the central part of Assam, that is the northern Assam or southern Assam, places like Guwahati, the awareness is good. So they present to some physicians, or some form of, at least an MBBS doctor they meet.
Okay.
But when you move from the city to rural areas, like there are places called as Golpara, Dudhnoi, Mangaldoi. These places are basically our daily wage laborers. They have no idea what they are going through. So So unless otherwise it becomes a proliferative disease, it's become stage 4, they don't meet the doctor. They just live with the disease.
Yeah, and do you believe, sir, like these are the gaps which is persisting in the prevention strategy, which is not met?
Yeah, the main key gaps in prevention is, the first thing is the low literacy rate. So that everyone should be educated about the cancer, and that early cancer is curable. And also they should know that the risk factors like alcohol, tobacco, these are all high
Sorry.
in risk factors, which has more than, tobacco has almost more than 70 known carcinogens. So they should be aware of all these things. And the second thing, more than this, the gaps, the reason is financial constraints. Not everyone is, see, we are a developing country, and not everyone is affordable for high-end facilities and care and treatment. And this one thing, another thing is the social implications, the social stigma. They don't want their family to know, they don't want their relatives to know, they don't want their parents to know, and elderly gentlemen and women, they don't want to be a burden to their children and family, so they don't tell unless otherwise it is known outside. They don't tell their family. This is the major gap
Even
why.
yeah, sir.
This is the major gap why the patient presents to us late. That is from the time to symptoms and tests. By the time the stage 1 disease becomes stage 4.
Yeah. So, do you feel, sir, that screening of cancer is that effective? Is
Yes,
it
of
like
course.
existing
Yes,
cancer
yes.
screening programs are effective?
Yeah. Effective. Yeah, of course. Yes, but we can make it in a large scale. See, there are there are a lot of other ways, like providing screening to diagnosis in a quick way, educating all rural health. Now everything has become social media, so everything has become digital. So creating more digital awareness, and there is also most of the patients, that is 5% of the patients, are most of the patients who are asymptomatic are picked up diagnosed during screenings.
So, do you
So
also feel, sir, like the accessibility of screening program and the awareness are also there in the people are
yes,
existing? Some.
yeah, it is. Yeah, definitely it is, yes, existing, but the denial is the most. They deny to get screened. The fear
Yes.
of getting diagnosed is hitting them hard. So they don't want to come and meet an oncologist. See, you can say, okay, you're more than 40, you have to get an echo scan. You can have to see a cardiologist. Okay, you're more than 50, you want to get yourself for diabetes. That is very common. But a person who is more than 40, okay, a women who is more than 40 in India, okay, I'm more than 40. There's a screening program. Every year I should get my mammogram done. Chances of breast cancer is common. That doesn't happen.
And the
That
follow,
doesn't
yeah, the
happen.
lack of follow up is
Lack of
still
follow-up
worse.
doesn't happen. They don't present. Just like how they get screened for echo, ECG, for cardiac evaluation, they don't get screened for cancer. It might be a social stigma, but still the reason might be a social stigma, but still they deny to get screened for cancer.
Okay, sir. Sir, in your perspective, what can be the a community level cancer prevention strategy and the
Yeah,
early diagnosis? What can be the strategies?
community level cancer strategy is, yes, community level. The major thing we can do is creating awareness and also screening camps in every other first tier, second tier, and third tier cities. And government can provide free screening kits for all the healthcare workers. And also in our institute, that is the Aishwarya Cancer Center, we have included even expensive tests like digital mammogram and ultrasound neck. That is, the digital mammogram is to diagnose breast cancer, ultrasound neck to diagnose thyroid cancer or any lymph node in the neck. And also we do pap smear to find out cervical cancer. So these are not included in most of the hospitals. So we wanted to make sure that every other patient who gets a master health checkup does a basic screening test for cancer. And this should be
And
common with all the hospitals in India.
and irrespective of infrastructure, sir, do you believe that workforce is still like sufficient enough?
Yes, the workforce is definitely sufficient in cities, not in rural area.
Rural setup.
So
Okay.
if you want to improve the number of doctors, oncologists working in rural areas, and practically that is not possible. So the other thing you can do is you can train all the ASHA workers and rural health nurses, midwives, they can still perform a pap smear. They can do the basic evaluation. And once the patient is diagnosed with some malignancy, you can always refer them to higher centers
Uh,
where facilities are
Tertiary
available.
centers. Okay. Okay,
Yeah,
sir.
tertiary centers, they can also always refer the patients. And one more thing is there can be a lot of digital awareness. See,
Okay.
Swiggy, Zomato, all delivery partners, they have so much of digital
Yeah.
awareness. But cancer, there is no one
Yeah, sir.
creating awareness among
Completely.
cancer. So recently, the doctors have been started doing social media informations,
Yeah.
carousels, so that everyone gets aware that these are the symptoms for cancers. The specific cancer, these are the drop down list. These are the red flag signs. So if this is there, it is alarming. You have to meet an oncologist. So this is how we can reach to people.
Reach to people. The digital media is activating more,
Yes,
as you
yeah,
said.
yeah, yeah. Because everyone is with digital media, no. Even go to
Mhm.
railway station, airport, school. Everyone is
Yes.
with their phones, using their swiping the reels with their
Yeah.
thumb.
That's
So that
true.
is the only source.
That's true. And sir, like, what is the current role of surgery in the malignant tumors? Like the
In
managing the malignant tumors.
Yeah, actually, basically, tumors, malignant tumors, there are multi-modality treatment. That is surgery, chemotherapy, there are targeted therapy, immunotherapy, and also radiation. So these are the different forms of treatment available for cancer. But surgery still remains the cornerstone of curative intent for most of the solid tumors. And
Mm.
beyond resection, surgery plays a vital role in staging the patient. So identifying the stage, and if it is a stage 4 surgery, can be used for palliation. And if suppose you say chemotherapy doesn't cure the patient with in one dose. So each
Yes, sir.
dose acts separately, and it takes time. Multiple doses of chemotherapy has to be. But surgery kills the tumor cells. That is the removal of the tumor cells, maybe not to 0%, from 100 to 5%, and rest of the other parts are taken over by chemotherapy or radiation or other multimodality treatment. But and also yes, the fear of surgery is always there with the patients. But now the recent days, there are in our center also we are performing a lot of laparoscopic surgeries. Almost 90% of our surgeries we are performing in laparoscopy, and also recently robotic surgery. We have been doing robotic surgery, the common surgeries where the patient was with the hospital with us in the hospital for 15 days. After
Yes.
laparoscopic and robotic surgery, they are getting discharged in 4 days. 3 days, 4 days, they are completely pain free. So the shorter stay plays a
So the
vital
quality
role.
of life after post surgery is that increased a bit?
Yeah, obviously yes. The hospital stay, which was 15 days earlier, is now only 3 days. So the quality
Okay.
of life for the patient, the recovery, their time to routine work, everything is shortened.
Okay, sir.
And the
Okay, sir.
recovery is also even quick.
And the like, sir, what is the what is the challenges what I have faced like providing the timely surgical care?
So major challenges in timely means, you mean the delay in treatment, or
So the
getting
timely
diagnosed?
getting like in terms of getting diagnosed, sir.
Okay. The
Timely
major
diagnosis.
reason why the patient's diagnosis is getting delayed is due to their fear. They don't want to get diagnosed. The first word of cancer, you have cancer, the breaking the bad news is a very difficult task for us. So they don't want to hear that. So they, even though they have start get developing the symptoms, unless otherwise it is bothering them, they don't get it screened or tested or diagnosed. So that is the patient's fear is the first thing. And the second thing is financial constraints. They
Yes,
know
sir.
the cancer treatment is expensive all around the world, so they don't want to put everyone at stake, so they don't come to the hospital just because they don't want to get diagnosed. And
Okay,
the
sir.
next thing is infrastructure, obviously. In shortage of specialized oncology doctors in
Oncologist.
tier 2, tier 3 cities is not happening. And the third thing is the patient might be the person who's having symptoms, he might be the only breadwinner of the family. So he waits for the days where he can take off without any loss of pay. So he waits for those days. It can be a few weeks or months, and or someone, the patient might be 60 years old. He has only one attendant, maybe his wife, who is 55 years old. So they wait for them. So the
Yes,
caretaker
sir.
of the patient also should be available. So they don't turn up to the hospital. So these are the major reasons why the treatment or diagnosis gets delayed.
So, how the surgical management influence the overall cancer outcome and experiences? How surgical treatment shapes it?
Yeah. The surgical treatment, as I mentioned earlier, it is a cornerstone for malignancy. But a good surgery is almost half the battle won. So, if a good surgery is performed, it might be after chemotherapy, it can be before chemotherapy, it can be after radiation, or
Okay.
after surgery we can give radiation. But surgery plays a vital role. So, we call something called as R0 resection. R0 resection is removal of all macroscopic and microscopic disease inside the patient. So that gives a patient a good outcome. Maybe he might require chemo, he or she might require chemotherapy after that. But that surgical thing is the major stone. And recent days, the with this advancement of robotic and laparoscopic surgery, the feasibility, the recovery, and also organ preservation. See, if a patient develops a bone tumor in the thigh bone, earlier days the removal of the leg, that is we called as amputation, that was the only modality of treatment. Now there are a lot of options called as limb salvage surgery. We can remove that specific bone, we can do a 3D printing
Yeah.
and create
Yes,
and
sir.
make the patient walk himself. And yeah, so obviously the surgery plays a major role in the outcome of the patient. So otherwise it has to be sequenced currently. It should be the decision. That is the why we require an oncologist. We have to the decision to operate first or give chemotherapy or radiation first. After that
That's
surgery,
depending upon
completely
properly on diagnosis.
diagnosis. Yeah, diagnosis stage and the type of the tumor.
Okay. Fine, sir. So as you previously mentioned the barriers and the advantages of the surgery, so how can you what is the system level changes that is needed to integrate the prevention, early detection and surgical cancer care?
The system level changes which can be made. See, for example, a decade or 2 decades before, cervix cancer, that is the uterine mouth cancer, that is cervix cancer, was the most common cancer. Now it is almost in the verge of eradication because of good screening programs and diagnosis, like vaccination programs. The vaccination, in the sense, from the age of 9 to 45, vaccination should be made mandatory. It is not mandatory now. The recent days, a couple of days, the government has started providing free vaccination for. I hope you
Yeah,
are aware
yes,
of
sir.
that.
Yes,
Free
sir. Yes, sir.
vaccination for that was
Cervical.
cervical cancer. HPV vaccination has been made mandate. It has been made available in all government setups for
Yeah.
free. That is recently, a week ago, I think, a couple of
Yes, sir.
days back.
And awareness programs are going on
Yes,
that
yes.
might
Now,
be on.
now cervix cancer has come. Rate of cervix cancer has come down because of private hospitals and other government hospitals having the vaccination program, and now government has given that free vaccines. So even more, it will drop down. But breast is not the same. There is no preventable vaccine for
Yes,
breast.
sir.
So we need a proper system level changes. So for breast cancer, there is no proper screening program. We have a pap smear for cervix. What screening program is there for breast? Patient has to undergo mammogram, which is not of free cost, only in certain government centers. So when the load increases, their wait time is too much.
Yeah.
They have a lump, they come and check. That is different. We are going to make someone get checked without a lump.
Yeah.
So
Yeah.
to make them come, their access should be very easy, and the
Yeah.
cost also should be free. That
Yeah.
is how we can. These are some system level changes that can be made, and also a national cancer registry should be made mandatory
Oh.
to track the outcomes, and also they identify the hotspots, which are the areas where people are getting avoided or not getting screened. So that roadmap should be there.
So
Once
the
the roadmap
barriers,
is in,
little barriers can be a little bit removed.
yeah, a
Something.
lot of changes can be made. You can target as a specific population. Like in this area, you make a registry, you report some 20 new cancer cases in a specific part of village, then you focus more on those villages and
Okay.
run more awareness camps, diagnostic tools. You can always create portable biopsy kits, portable mammogram missions to get them screened if they are not able to travel. So portable mobile cancer screening vehicles, all those can be provided. So next thing can be, we can make mammogram free for all women, the cancer health checkup, free cancer health checkup for all men, colonoscopy or so
Yeah.
sigmoidoscopy to find out
Yes, sir.
colon cancer for anyone more than 45 to 50 years, or with
Mhm.
any family history. So these are the small changes can make a lot of difference in the system level.
Yes, as you explained very beautifully, sir, a lot of things we get to know from you, a lot of information. At the end, do you want to add anything for like us regarding the improvement of cancer strategy? As you add a lot of things, but anything from your end without aparting
Yes.
from our questions, if you can add.
I just would like to tell the common people that prevention is always better and cheaper than cure. So don't think about the small amount that you're spending for mammogram or any biopsy or any doctor
Yes,
visit. No. Because once you're
very
diagnosed in an advanced stage, your cost will go very high. So
yeah,
a small amount, it's just like you're investing on your health. We are
yeah.
investing on so many things,
So many
unnecessary
things.
things,
Understand.
which spoils our head, junk food, late night parties, unnecessary trips and tours. So you can invest those small amounts in taking care of your health. Invest in your health. So once you
Yeah,
invest
sir.
in your health, the prevention starts right away from there. So prevention is always better than cure and cheaper than cure. The second thing I wanted to tell is, if possible, I advise all Indian citizens to take health insurance. So that can all,
Okay.
it is also an investment that always stays in the back to like a strong backbone, so that anytime you can, if you have an insurance, you're confident enough that if you go to the hospital, you can get
Yes,
diagnosed also. Someone is there to cover your
early
financial
stages.
burden.
Early
Early
stages can
stages,
be.
yeah. So the main goal, what I wanted to target is the number of stage 4 cancer diagnosis should be nil. If anyone is getting diagnosed to have cancer, it should be in the early stage. And the next target for me is the rate of cancer, the number of cancer cases, even when diagnosed in stage 1, even the patients who are getting diagnosed should also come to nil. So that is the time when we say that screening. See, screening, the number of stage 1 cancer is reduced, then it means our screening is very good. If a number of stage
Yes, sir.
1 cancer diagnosis is high, it means that our screening is very good. If there is no cancer diagnosis at all, it means our prevention is very good. So
Very good.
these two
Yes,
things
sir.
should be covered. Apart from that, a
Thank
proper referral system should be there.
you.
A gynecologist seeing a patient with bleeding from the vagina, then she is suspecting malignancy, she should immediately refer the patient to an oncologist. A dentist seeing an ulcer or wound or growth in the mouth, they should immediately refer the patient to oncologist. They should not delay time. Any doubt of any cancer diagnosis doubt, immediately they have referred to a higher center or to an oncologist. And also the availability of drugs like chemotherapy and immunotherapy drugs should be made even more cheaper, even in government setup, so that the people can have access to high end drugs. So these are the common things I wanted to tell the people about. You're not audible, man. You're not audible.
Sorry, sir. I somehow get muted. Thank you so much, sir. It's a very interactive session actually, and we get to know a lot of things, lot of ideas, what can be implemented, and what the prevention strategy can be, and very basically like the early stage of planning. That is very informative for us. Thank you for your cooperation so much, sir.
Thank you. Thank you.